Hello and welcome everyone to our latest presentation on long COVID. The term long COVID was first used in this BMG opinion blog. This was basically written by a professor of infectious disease of Liverpool. He was personally suffering from this disease and he had written this blog about his experience with COVID-19. He was suffering for the last 7 weeks and he had casually termed it as long COVID. However, it was picked up by the Twitter and the term long COVID started trending, and since then we have had a lot of papers on it. Now, this is showing that there are almost 43 original articles, multiple systematic reviews, case reports, letters, guidelines, even consensus statements on long COVID. Most of them are observational studies, cohorts, case control, cross-sectional studies. Some RCTs are also there. Now, if we look into details as which aspect they were covering, most of them were covering on the symptomatology, rehabilitation, general care, the thromboembolic events, the various manifestations of long COVID. Now, as you can see over here, the number of papers on long COVID has been increasing, and so basically this presentation is to summarize what we know till now regarding long COVID. According to the NICE, the definition is the symptoms that continue or develop after acute COVID-19 infection, which cannot be explained by an alternative diagnosis. This term includes ongoing symptomatic COVID-19 from 4 to 12 weeks post-infection and post-COVID-19 syndrome beyond 12 weeks of infection. However, NIH and follows the US CDC definition, which describes the condition as a sequelae that extends beyond the 4 weeks after the initial infection. So more or less, the 4 weeks is the time which most of the societies agree is the place where we call long COVID. There can be two types of symptomatology. One is a post-acute COVID or something a chronic COVID, where the patient has mild symptoms, but they continue for a long time. So this post-acute COVID and chronic COVID is what is termed as long COVID. Now, epidemiology. The reported incidence and mortality rates of COVID-19 vary between countries, making it difficult to accurately predict the number of patients who will progress to long COVID. Now, the current disparity in this mortality and incidence is because of the difference in the length of follow-ups, the population getting assessed, the accuracy of self-reporting, because most of the symptoms are something which will be reported by the patient, and not everyone reports because not everyone knows that these could be features of long COVID. And since it's a pandemic and so many people are getting affected, it is difficult to know exactly the incidence of this long COVID, because most of the time it is underreported. People don't understand that these are actual symptoms of long COVID and they do not get themselves checked. Now, what are the manifestations of this long COVID? So the symptoms of COVID can be divided into two. The first, as we have already seen, is the acute stage of illness or short COVID. However, within the 4 weeks, not everyone recovers. Now there can be two things now. Either the old symptoms are persisting or there is a new symptoms arising which we can say is specific for long COVID. Now old symptoms can improve, but they can result in sequelae of the infection and sequelae of the chronic illness could be there in the patient, or they may not improve because there is a reinfection with virus, fungal or bacterial infection, or it is possible that even the inflammation is still ongoing. However, a patient who was not so much symptomatic can develop new symptoms, which can be because of the complications of COVID, the complications because of their comorbidities, complication because of some treatment they have received, or some non-specific hospitalization effects like psychological. So if we classify, these symptoms can be divided into multiple types, like the post-COVID fatigue syndrome, post-COVID cardiovascular syndrome, neuropsychiatric syndrome, GI syndrome. Almost all the symptoms in the body can be affected. But the most important symptoms that we see is the fatigue. This is the most common symptom, and it is the most common reported symptom with long COVID. Now, a 5-week prevalence of 11.9% was seen among patients with COVID-19 in UK population. Now, the reason for this fatigue can be multiple. Definitely, the psychological and social factors of being in isolation and the pandemic has a different effect, but there are structural causes as well, like the pro-inflammatory cytokines and the release of the free radicals results in damage to the nerve terminus and muscle fiber. There is actual damage to the sarcolemma resulting in fatigue. Apart from that, there is also neuroinflammation which also results in a fatigue. The next and the most important again in terms of symptomatology is dyspnea. There is a persistence of dyspnea, even new onset dyspnea after 4 weeks in patients with COVID-19. Now, this incidence is around 5%, and this is, as I said, regardless of the presence of respiratory distress within the 4 weeks. Patient can develop it even after 4 weeks without any severe symptoms in the first 4 weeks. This can result in abnormalities in the lung function tests like diffusion capacity, total lung capacity, forced expiratory volume in first second, forced vital capacity, small airway function, all can get affected in this type of presentation. Now, again, the most important thing is there can be three things that can happen. The first is there is a persistent inflammation inside the alveolus. As you can see over here, the alveolus is still infected and there is a still ongoing inflammation. The second, and which is the most important that we see very commonly, is the presence of fibrosis and fibroblasts. These fibrosis and fibroblasts can result in fibrosis of the lungs, resulting in decreased oxygenation and increased dyspnea. And the last but certainly not the least is the presence of blood clots. As we have already seen, the immunothrombosis is an important pathogenesis of COVID-19, and this, when present inside the pulmonary circulation, can impair the oxygenation and ventilation of the patient. The next important thing is the cardiovascular abnormalities. Various cardiovascular abnormalities can be seen like myocardial injury, SVT, bradycardia, heart failure, ventricular tachycardia, sudden cardiac deaths, and impaired quality of life. Now, this, as we have already seen, is again because of the inflammation that still goes on. If we see the inflammation of the myocardium, it is divided into three phases. The phase 1, where the virus enters and activates the immune system. The phase 2 is the activation of the acquired immune response, which is around 1 to 4 weeks. And finally, we get a recovery phase. However, this recovery phase is because of the clearance of the virus and the normalization of the LV function. This may not be achieved in all cases. So there is a persistence of inflammation, there is dilated cardiomyopathy. Let's look more into it. If we look more details, there is this presence of this inflammation and the inflammatory cells, especially the T cells and the monocytes. They affect the myocardial function, causing myocyte death and myositis of the cardiac myocardium. The second part is there is an autonomic dysfunction, which, as we already know, there is a neuroinflammation and this can cause an autonomic dysfunction which can affect the function of the heart. The next is the presence of these fibroblasts. Once these fibroblasts are present, they make it difficult for the heart to contract. And as you can see more closely over here, there is a displacement in the desmosome proteins. As these desmosome proteins get displaced, the contraction of the heart is decreased. Because of this presence of these cardiac fibroblasts, the contractility of the heart is affected, resulting in dilated cardiomyopathies, decreased LV systolic function, and arrhythmias. Now, summarizing the cardiovascular and respiratory pathophysiology over here, you can see that this is a normal alveolus. This is the alveolus which has been affected by COVID-19. As you can see over here, it's no more smooth and there are a lot of contractions and difficulties. So this makes it difficult for the oxygenation to traverse, resulting in increased dyspnea. And here we can see that it also affects the vessels. Here you see the intersusceptions in the small microvasculature. This over here shows a endothelial surface. Here the RC is the red cell, this is the endothelial cell, and in this endothelial cell you can see there is a persistence of the COVID-19 virus. Now this is seen even after 4 weeks. These are the images which are taken after 4 weeks. So there is a persistence of virus, there is a persistence of fibrosis and inflammation which affect the cardiorespiratory function. The next is the cognition and mental health. Encephalopathy, cognitive impairment, cardiovascular events, hypoxic brain injuries, various neurological manifestation can affect in COVID-19. One of the most important is brain fogging and sleeplessness. Now this is again because the restraint microglia which is present gets activated, and there's a persistent chronic inflammation which results in the neuroinflammation and the stimulation. These result in various neurological manifestations. Apart from that, we all know the blood clots can happen anywhere in the body. The presence of leukocyte infiltration can give a picture of encephalitis. As we already know, there can be autonomic dysfunction, and last but not the least, the brain fogging, the cognitive impairment can also occur. This can be because of the combination of all these effects and also because of the social and the psychological effects. The next is olfactory and gustatory functions. This is something which you have been knowing since a long time, that if these are affected, then it signifies a COVID-19 infection. But these symptoms can persist even beyond 5 weeks, with a prevalence around 10% in patients who have been affected with COVID-19. But in some studies, they say the incidence can range for even 11 to 45%. So there is a very high persistence of these problems even after the COVID-19 has recovered. This again can be because of two reasons. For the first is the neuroinflammation. The second is the retrograde transmission of the virus and resulting in a dysfunction of the nerve function. So apart from all this, the kidney can get affected. There can be incidence of acute kidney injury. There can be incidence of pancreatitis, thyroiditis, and various other organs can get affected because of COVID-19 directly. So when a patient comes after recovery, we can divide them into first assessing, into give them a questionnaire, do some lab tests and blood tests, then try to classify them into having which type of symptoms of long COVID. These can be mild, which may require home surveillance, moderate, which can require community therapy or telemedicine, and finally severe, where we need to admit these patients for their betterment. So just elaborating on this a little further, there are certain risk factors which predispose a patient to developing long COVID. We have already known that male sex is a risk factor for mortality. However, it is not a risk factor for long COVID. Female sex is a higher risk factor for long COVID. Apart from that, if the patient had more than 5 symptoms initially, increased severity of illness, increased T dimer and CRP levels, increased lymphocyte, they are more prone to long COVID. Apart from this, COVID related, there can be also factors like pre-existing comorbidities, bias, psychiatric disorders, old age, all these can affect and result in long COVID. Now the pathophysiology, as we have already seen, it is a long-term inflammation which affects the cardiac, pulmonary as well as the neurological function, or there can be unresolved inflammation in the gut affecting the autoimmunity, lymphopenia and the viral persistence. Now, there can be two ways by which we can deal with it. The first is personalized rehabilitation, light aerobic exercises, breathing exercises, which are suitable as per the case. The next is pharmaceutical, where we can give certain drugs. As of now, none of the pharmaceutical methods have been very much effective. So we still go with mostly the non-pharmaceutical like compression garments, exercises. This is a score which can be done to assess the functionality of the patients who are coming to the OPDs for long COVID symptoms, to whether to monitor them over a period of time for improvement in symptoms, for improvement in functional status, as well as the mental well-being. So basically, COVID-19 can result in various endpoints. So the patient first gets affected. In stage 1, it's a mild disease. Usually it results in a recovery. However, if there are moderate symptoms, then obviously the symptomatology can be aggravated, so it can go back or it can result in death also. In stage 3, again similarly, it can either result in death, which occurs in a large number of cases, or it can result in full recovery. However, there is a other stage, that is a stage 4, where the patient never goes back to the health level which they were. So this results in a new baseline of health being established. So the patient has to be on that reduced level of health for the rest of his life. So to summarize how to deal with this, how to treat the disorders, the first is the diagnosis of COVID-19, then the diagnosis of long COVID. We need to understand the symptoms. We need to do tests and review these patients, do psychological assessments to find out if they're suffering from long COVID. The assessment has to be done in a holistic, patient-centric manner with good clinical and appropriate examination, with good education to the patient so that they are able to tell their symptoms. The next is investigations and referrals. We need to do proper investigations like proper imaging, proper blood test, proper psychiatric evaluation, and referral to various subspecialty if there is a specific symptom like neurological, nephrological, or cardiovascular. Now, the plan of care has to be done with discussion whether we should deal with it at a home level, or if the symptoms are severe, we admit the patient to the hospital. Now, the management, as we said, it can be self-managed where we advise and they do the thing, or we need to give support to extreme of ages like old patients and children, and it has to be multi-rehabilitation with the help of psychiatrists, psychologists, physiotherapists for the rehabilitation of the patient. Then we need to follow them up. We need to follow them up at least every 4 weeks if they are having severe symptoms, or if they're having mild to moderate symptoms, they can be followed at a larger interval as well. Sharing of information and continuity of care is important. If the patient is getting admitted with severe symptoms of long COVID, there must be a continuity of care because these patients can suffer from this for a long time, and this record must be kept, and they must be encouraged to follow the advice till they develop a full recovery. Finally, we do need service organization at community level who can deal with these patients and who should give local level knowledge, skill and training so that these patients get recovered. Thank you for your patience and check our website for further information.